أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. I am Professor Dr. Ali Heather, and I am on the sessions reporting of the X-ray chest plane after a very long sessions of how to read the X-ray. When a clinical person is reading the chest X-ray, it is a different version than the radiologist, because radiologist does not know about the patient, because he had not taken the history and examination, and he is not go to the hospital bed and see usually what is the problem is going on. And on our side, the RMOs who have ordered this X-ray, mostly they do not provide information to the radiologists. This is the hallmark, that we have to read the X-ray ourselves. So I am doing this one. Now I reached up to the case number 12. A 60-year-old smoker who had done the percutaneous transduvenous coronary angiography 3 years back after the non-ST elevation myocardial infarction. He was a smoker. He had been attacked by the NSTMI, experienced effort intolerance. Now, after 3 years, he experienced effort intolerance, initially in walking and then at the rest 2 weeks back. Remember that smokers and who are not taking the secondary prevention, there are chances of the blockage of the stents which were placed. This is my message given to the students and fellows. Please try to convince them for the secondary prevention and cessation of the smoking. According to American Heart Association, they have got very strict response on this PTCA. They said if the patient does not consent to quit smoking, do not do PTCA, because it will block very early. Anyway, so he has been the shortness of the breath 2 weeks back. Last night he had attack of suffocation during sleep. This is probably the paroxysmal nocturnal dyspnea he experienced and presented to us in the morning OPD. In our morning OPD, we examined this patient. The temperature was 98, the pulse was 122 per minute. It is tachycardia, which is seen here. The blood pressure was 170 by 100, and respiratory rate was 24 per minute. It is tachypnea. The pedal edema was positive. The tender hepatomegaly 3 centimeter below the costal margin, and JBP was raised, and there were fine crepitations at both lung bases, and also on close auscultation the S3 was audible at the apex. The investigation was done. The hemoglobin 17 gram, total leukocyte count 7,900, platelets was 4,30,000, ESR is 50 per millimeter per hour, random blood sugar was 190, urine RE was proteinuria. There was also glucose urea in this patient, although the patient was non-diabetic. But you have to screen for it. And in my opinion, those patients who are smokers have done PTCA, they enjoy all way of life, eating everything now, and they thought that after doing PTCA or by CABG, there are no problems at all. The life is smooth. No, no, no. There are chances of the development of this metabolic syndrome. There are chances of development of the diabetes mellitus type 2A in these patients. So ECG was done. A lot of findings are seen. One thing is this is the left axis deviation with the heart rate was 120, 22, and it was low voltage ECG, and there were non-progression of the R waves and T wave inversions were noted in V1, V2 and V3. X-ray chest PA view was done and present to you for the reporting purposes. It is a common problem, very, very common. We seen this type of scenario. So the X-ray was presented to you. Now report it. First of all, the requirements. It is a PA view, yes, because the vertebral spine is masked by the middle mediastinal shadow. This is the important finding in this patient. Although the patient does not actually have raised arms properly, so the supraclavicular fossa are not very wide here. It is a frontal view projection, dominant PA view. This is the statement you have to give. Secondly, the patient should be standing still and straight. Now, straight is concerned, first of all, S for straight. The Spanish process, this is the another Spanish process. This is the another Spanish process. It is going like this. Patient neck was on this side. So on this side, he has bending. The neck was bended on the right side. That's why he was not straight. So after that, he was not straight. The comment on the trachea is difficult. So one parameter is lost. The second one is whether the patient was standing. Yes, this is the first interest, second, third rib, fourth costal cartilage, fifth costal cartilage, sixth costal cartilage, seventh costal cartilage, and this is the dome of the diaphragm. The dome of the diaphragm is seen here. Here, dome of the diaphragm. It is, you see much here. This is the dome of the diaphragm, which is not visualized. Whatever is seen in this X-ray should be commented. So it is not visible. Now, thirdly, he was deeply inspired and hold the breath properly. It is not the expiratory film. Why? Because the bronchovascular markings are visible in this X-ray. So the requirements are fulfilled. The quality film is not good because the lower part was not done properly. Lower part of the X-ray doesn't show diaphragm and the gastroenterograms and the liver shadow, etc. Now go for the bony skeleton is concerned. The clavicles are normal. The scapula is here. It is the medial border. Here it is the medial border. Although the patient has not raised the limbs properly, and he's bended the neck. Now this is the first ray, this is the second one, this is the third, and this is the fourth, and fifth, sixth, seventh. Here is the 1, this is 2, this is 3, this is 4, 5, 6, 7. Anterior projections. What we do here, these are the lungs, because the trachea was not under comment, because of the bending of the necks. Although it is like this, 10 degrees towards the right side, although it is normal position, but do not comment on the trachea because of the bending of the neck. You cannot comment on the trachea. Confidently, you cannot. Now, the first intercostal space, second, third, and fourth. The first rib, the second, upper border, lower border, upper border, lower border. Here, I think it's same thing. At the anterior projection of the second rib, draw a line linear to it, and at the fourth rib, draw a transverse line here. So there are 6 lung zones: right side upper, middle, lower; left side upper, middle, lower. There are 6 lung zones or areas. In these areas, 2 components are commonly present. They are aerograms and the bronchovascular markings. The third one, if anything is seen, should be labeled as alien, or it should be radiopacity or pathology. Now, the supraclavicular fossa will be compared with another one, the first intercostal space with the first intercostal space, second with the second, third with the third. Now, in comparison, I see that this is very hypertransulency is there in this left side of the lung. Although on the lower side there is haziness are seen. The dome of the diaphragm is not visualized properly. Haziness is seen definitely. And on this side, on the right side, I see the bronchovascular markings are very thick and very prominent, and they are going out of the hyla and touching here. So this is the congestive changes are seen in these lungs. And very, very close observation. These are the linear markings. These are the Carle B lines. These are the congestion. This is the congestion of the lymphatics, pulmonary lymphatics, which causes the B lines. And this indicates that the patient has pulmonary edema. Evidence of radiological evidence, very initial. Because the darkening of this on the left side, on the right side these are the markings and going up, upper lobe divergent. These are the lines which are called Carle A lines. From the center, these lines are coming very thickly populated lines. They are Carle C. C means central lines. Pathognomic is Carle B lines for the pulmonary edema. Now this is the comment on the lung fields. Dome of the diaphragm, although it is not visible, it is very flat. You can see flattening here, although this part is not visualized very properly. This part is visualized, although the costophrenic angle is not clear. Cardiophrenic angle is clear, but it is flat dome of the diaphragm. Here it is probably the flat also, and there is haziness above there. Probably this patient has an evidence of the pleural fluid in this area. We cannot comment on this because the lower part is not visualized. Whatever is seen should be commented, definitely. This is the rule of the radiology. And extract knowledge from it as much as you can. And then we go for the lower part of the middle mediastinum. This is the left border of the heart. This is the right border of the heart. The left border here, it is curved up, changes its direction. The right border changes the direction here. 1 point here and 1 point here. Now, join the 2 points. This one is slightly oblique. It is upper part of the middle mediastinum. And this is the lower part of the middle mediastinum. The lower part of the middle mediastinum means that the heart and its coverings. So, there are 2 questions regarding this. First of all, size. Comment on the size. It is definitely the cardiothoracic ratio is increased. There is cardiomegaly, enlargement of the heart. I am not saying hypertrophy of the heart. I am saying the enlargement of the heart. And then see the apex, which is moving down. It is going up and is down. Is it predominant left ventricular failure rather than a right ventricular failure? the dominant left ventricular failure is there. Although there are elements of the right ventricular failure also, but the dominant left ventricular failure. As far as shape is concerned, it is not normal, because it is just like this one. It's very, very, not curved type of a left border. It is moving here up and then move there. So upper 1/3 and the lower 2/3. Upper 1/3 represent here the atria, down there the left ventricle. The right border, the upper 1/3 represent the superior vena cava entry, and the lower 1/3 the inferior vena cava entry into the right atrium. Remaining 2/3 is representing the right atrial border. It is indirect view of the right ventricular stress on this right atrium. The right atrium is not visualized. Now, coming afterwards, these are the comments which I have given. Actually, there is nothing abnormality seen here. We go up. There is a cardiomegaly. It is predominant the left-sided type of the cardiomegaly, left ventricular failure, most probably. And then we go up here, the upper part of the middle mediastinum. 4 parts, 1, 2, 3, 4. Now, see, the first part is ascending aorta, the second and the third is the arch of the aorta. Here the aortic knuckle you see, this one, and down there is this projection. You see this projection? This is the pulmonary conus. It is very prominent here. This one. It's moved like this. This is evidence of the increased pressure in the pulmonary artery. The reason is manifold. This is the description of the upper part of the middle mediastinum. The hala are visible here. A C-shaped, lateral C-shaped hala, left side, 2.5 centimeter, 2 centimeter. It is normal in its morphology is concerned. And on the right side of the hyla, this is the stem, this is the upper part, this is the lower. Very, very prominent hyla are seen on this side. And see the branches are coming out as the bronchovascular margins. So this is the upper part, this is the lower part. Prominent hyla was seen on the right side. So inference is that this patient, although not in a normal state position, and the quality of the film was not good, because the lower part was not visualized and the dome of the diaphragm was not visualized properly. Although the positive findings in this patient is the compensating emphysema on the left side, and there are congestive changes seen on this side because he was a smoker. Remember, I told you he was a smoker. Then we go for the cardiomegaly is there. You see it is predominant left-sided cardiomegaly with the pulmonary conus is prominent, means there is evidence of increased pressure in the main pulmonary trunk. And this is the inference. The conclusion is means that this patient is probably in the congestive cardiac failure, dominant left ventricular failure. Although there are signs of the right ventricular failure also. And the scenario which is given, there are a lot of findings of the left ventricular failure more than the right ventricular failure. That is why I say it is congestive heart failure. To go for the other investigations, lateral view can be done. It can be done the echocardiography. You can do what is called as the atrial natriuretic peptides derivatives. There are many derivatives, pro and other derivatives are available. although they are not the diagnostic of the congestive cardiac failure, is only diagnosed on the basis of clinical examination and on the Framhamming criteria. Now, he described non-modified Framhamming criteria is available on your internet. You can see the two major findings, so one major or two minor findings will diagnose the case as congestive cardiac failure or cardiac failure. So other investigation should be done. Other than that are the liver function tests, urea creatine electrolytes, the ABGs should be done in this patient. Remember, this patient is a patient of the chronic obstructive pulmonary disease also. So you go for the pulmonary function tests also to confirm that he has COPD. Now it is progressing. The case can be referred to the pulmonologist because I am internist. I can handle this case well as an overall patient. I can deal with the COPD. I can deal with this type of the problem, that is heart failure. That is the advantage of the internal medicine. That is the beauty of the internal medicine. The patient the patient is usually presenting many features of the different systems, and you are analyzing all systems. You are able to analyze all systems and make a diagnosis or a differential diagnosis, work on it, manage the patient well. That is the beauty of the internal medicine. Although it is not an easy subject, it is a difficult subject, it is a very wide subject. But this is the beauty of the internal medicine. According to my friend who is residing in the United Kingdom, he said that internal medicine for him is the addiction, just like addiction to anything. He is addicted to the internal medicine. So this is the story and the reporting of the X-ray. I hope you like this reporting, and there are few X-rays or more to be described, and then we will switch to the pulmonary function test. Inshallah, we will meet again. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin wa ma alayna illa al balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.